just checking here with, the refinement. And, I don't want to remove too much of the palatal surface of the crown, but I do want straight line access. I am angulating my burr in the wrong direction, so if we draw kind of a little bit of an arrow here, we can see that if we were to drill any further, this is going to go out of the tooth buccally. Another problem with a small access is cutting off the GP. Because I'm using the single cone technique, So hello, welcome to today's Friday clinical case. The learning objectives around today's video is essentially accessing upper anteriors, and really show you how to do a root canal and a upper central as well. But what I like to do is, we've got an Instagram page, it's very popular. We get to get lots and lots of messages and comments on the little shorts that we do there. And also, I'll look at all your messages on YouTube. And one of my most viral videos is accessing a canine. I've kind of sectioned a canine in two. And what I've noticed, there's a bit of a theme with the messages on this particular video, is the discrepancy between the people who think my level of access is too excessive compared to another group might say that they're happy with this level of tooth removal to access the tooth. So what I wanted to do is I want to address the sort of elephant in the room, shall we say, regarding access upper anteriors. And in this case, because the tooth was a crown, I wanted to limit the removal of tooth tissue as much as possible. But I want to show you today there are negotiables and there are non-negotiables when we're talking about access. So there are non-negotiables, the things that have to be done to ensure that you can clean the tooth appropriately, but then there are things that you can kind of, there's a bit of a blurred line, shall we say, with regard to access. So before we get in the specific case, what I do want to say is that when we look at the metrics of the channel, over 50% of the people who watch these videos are non-subscribers. So if I could ask you to do one thing, it's quick, it's easy, and it's free, it's just to hit that subscribe button. If you hit the subscribe button, it supports the channel, and I promise each week, each video will be getting better and better, and the educational content will get better and better and better. If you really, really like these videos and you want to support the channel even more, we've got a membership program. The membership program gives you early access to content, so we're usually running about 3 or 4 weeks ahead with these videos, so you get to watch them much earlier. And also we've got exclusive content. We've got an amazing endodontic access video. It's about an hour and a bit long, and it just gives you all the tips on how to access teeth endodontically. And we've also got a newly qualified survival guide sort of video for the newly qualified dentist on what to do with root canal in your first week. So we'll get on with the case. This is a case of an upper central. It's an upper left one, and this tooth had received some nice aesthetic crowns in the recent past. And the tooth then became symptomatic. The tooth was painful, and there was a diagnosis of irreversible pulpitis / pulpal necrosis in this case. And obviously the patient was consented and she was happy to go ahead with treatment. And when we look at the periplug radiograph, there are a few things that I'm slightly concerned about. The first one, of course, is to access through the crown. We're going to make sure we don't perforate the tooth. The second thing that I see with this x-ray is that it's quite wide, so to obturate this tooth is going to be relatively difficult. I suppose in a way you could argue as well that the coronal third, maybe the pulp chamber isn't as large, so accessing this teeth is going to be difficult to reach down. And also when we look at the apical end as well, it looks like it disappears slightly. So is that because it's gone small or is it split? So these are all the things that you're thinking about. But what we want to concentrate on today is the access. And if we move over to the video here, we can see that we're just sort of assessing the tooth here and sort of thinking to ourselves, well, we're going to access this tooth, we're going to go through the crown, we've lost all of its anatomical landmarks, so we don't want to perforate the tooth, and I'm placing the rubber dam on now. I kind of used to access the tooth first, but I'm seeing now that really the rubber dam kind of moves the gingiva out of the way, and actually we can see where the CEJs, we can see where the root is a little bit more clearly in most cases. So in this case, with this tooth, I am going to place rubber dam on straight away. And then when we put the clamp on here, I notice that the clamp is sort of sitting a little bit too buckly, so I just need to adjust this so I've got a little bit more access, and also I give it a little bit of a wiggle so the rubber dam sort of reaches underneath the clamp and gives us that kind of nice tight seal. I'm now going to start my initial access, and in this case I'm going to use a pear-shaped burr. It's too short for us to do the proper access, but I feel like with these pear-shaped burrs, it's got quite a wide base, and also I think it cuts through crowns a little bit better. And I'm just doing a little bit of drilling, having a little look, a little bit of drilling, having a little look, and sometimes you feel like you've drilled loads and loads and loads and you have a little look and you've not gone down that much at all. I'm going to swap out my burr, and then I've noticed here that I am angulating my burr in the wrong direction. So if we draw kind of a little bit of an arrow here, we can see that if we were to drill any further, this is going to go out of the tooth buccally. So what I need to do is I need to just kind of adjust my angulation of my burr a little bit further palatally, and we can see that it looks a little bit better now. So if we've just adjusted it, so I'm going to go back in with that, being mindful of my angulation of my burr, being a bit more careful, and then as I kind of drill into this tooth, what I can see now is that I'm placing this Mach 2 plugger to the bit now where I am drilling, and we can see that it's in the correct angulation. It's going down the long axis of the tooth essentially. So we know we're in the correct orientation, and then I am going to get my fast handpiece again with that kind of torpedo shaped burr. I'm going to drill down, and then I feel for that kind of characteristic drop into the pulp chamber. So I'm gonna have a little look, but I can't really see any obvious access. So I'm gonna do a little bit of irrigant, and I'm gonna use a orifice opener. So this is quite a short rotary file, but it's quite a high taper, so it's quite fat. So it's gonna sort of open out the canal orifice, and we'll give it another little bit of an irrigant, and then we can see that we've breached the pulp chamber, but the hole is still too small. There's overhangs here. This is going to be incredibly difficult for you to shape, clean and obturate with the hole and the access in this situation. So what I'm going to do straight away is I'm going to use some ultrasonics here. So this is a dedicated endodontic ultrasonic unit with the tips are diamond coated, and this you can see here that it opens up the canal, but it still needs a little bit more refinement essentially, and you want to use these really judiciously. In this case I use it without water, but you've got to be careful you don't fracture the instruments here, because putting too much energy down them can make them heat up and break. And then I noticed that the ultrasonic is slightly marking the crown, so I do need to be careful. So being down the long axis of the tooth, sometimes you can be, you can sort of cut into the inside ledge, so you've got to be super careful there. And then just checking here with the refinement, and I don't want to remove too much of the palatal surface of the crown, but I do want straight line access. So I'm just being very careful. The great thing about these ultrasonics is just nice and easy, really simple and very slow at removing things. But the thing, one of the non-negotiables about accessing an anterior teeth is removing that lingual shelf. So it's kind of like a hump, which it's really difficult for you to obturate the tooth with this hump in situ. So I've removed a little bit of the lingual shelf here, but I just need a little bit more removal. And as we sort of remove it and we irrigate it, and we can see, again, it looks a bit better, but there's that kind of hump here, which still just needs to be removed. I personally, using a microscope, I like to see the vast majority of the canal, and if this hump, this lingual shelf is in the way, then you know, it obscures your ability to see the canal space itself. And after we've done all of our investigation here, all of our lingual removal, we can see that hump is completely gone, and we can see the vast majority of the canal. But we can see there's kind of a little bit of a ledge here, and this is kind of the transition between the lingual shelf and the pulp horns. And this again will be difficult to obturate right at the end. So the irrigant will flow down there, but once you try to obturate the coronal aspect of this tooth, and then also fill it with a restorative material, say like flowable bulk composite, you know, it might be a space where bacteria can proliferate. So once we've removed this kind of little ledge, I'm going to gain the working length of the size 10 K file. But what I notice when I hook up this apex locator to this ham file is that just the readings are absolutely all over the place. So even any kind of movement, left, right, up, down, the apex locator is out, in, out, in, out, in. And what I do in these situations is, if the size 10 is not giving a great reading, it's because the ham file is too narrow for the opening. So I'm going to flick the size 10 K file out, and I'm going to use a size 15. And in fact, the evidence suggests that using a size 15 is more accurate for working length measurements. And we can see here when we hook up the apex locator to this size 15 K file, we've got that more accurate and controlled reading. So as I push this size 15 K file to length, the corresponding measurement on the apex locator is showing that it's moving at, you know, a relatively the same kind of rate. So with the apex locator, we're going to push it out the apex, so we get an over reading, and then we push it back, and that's our zero reading. And the zero reading here is 22 millimeters. So a proper motor along here. We've accessed the tooth. It looks all really, really nice, and now we're ready to do some shaping. And what I notice is that because the canal space is quite wide, I'm going to go straight for my final shaping file, which is a size 25 HyFlex. And this actually reaches really, really quickly to length. So in this case, I don't often do this, is I'm going to obviously recapitulate with my size 15K file to make sure that the canal space is still open. But now I'm actually going to use a final shaping file. This is a WaveOne Gold 35 reciprocation file too. That will be essentially our master apical file. We're then ready to do our cone fit radiograph, but actually as I place the matched cone, the WaveOne Gold 35 to length, it pushes past the working length, indicating that the apical end on the tooth is wider than the final shaping file. So we need to do a little bit of apical gauging. Obviously we pull this out and we can see that it's the GP cone fits at 24 millimeters, 2 millimeters away from our working length. So I'm going to use a higher diameter file here. I'm going to use a WaveOne Gold 45, and you can see here that it's just a little bit thicker than the 35. We push it to length, and again I notice that it does push past the zero reading on the apex locator, but not as much. So we pull it out, we measure it, and it's working about at 23 millimeters. So we're not too far off. So we don't need to go up another GP cone. Essentially what we do is we just snip off the GP cone at 50. So we used a specialized GP cutter here. So we've gone from 45 to 50. And as we push this GP cone to length, it fits nice and snugly at the working length, which is 21.5 millimeters minus, this is minus 0.5 millimeters away from the zero reading. And then we place the GP cone to length, we can kind of feel that lovely tug back. You can see I'm just having a nice little, and you can see here now we've got a nice bit of tug back on that. It looks really, really nice. We're then going to take our cone fit radiograph. I like to cut the excess off the GP cone for a number of reasons. And essentially when we're taking an x-ray, what I like to do is I obviously like to remove the frame. I fold the rubber dam so I can see the frame through the rubber dam. And then I use just a normal ended PA holder here, because I feel like using a specific root canal endodontic holder. It kind of gets in the way, and because I'm using that kind of butterfly rubber dam clamp, the conventional periapical radiograph holder goes in the specific hole between the two sort of butterfly between the butterfly clamp essentially. And when we look at the cone fit radiograph, we're to length. Looks fantastic. I'm very, very happy. And then we're ready to do our final obturation. And of course, whilst the x-ray is being developed, I like to clean everything up and get set up. I clean the tray, and then I've got this GP disinfecting ring. We're using EDTA, and then I'm going to fill up another well in this GP disinfecting ring with sodium hypochlorite, and then finally I'm using isopropyl alcohol, and this is used to clean the GP cone once it's been in the sodium hypochlorite. And in this case, because it's quite a wide open apex, I'm going to use these size 50 paper points. Downside to this is these are not sterile, but I'm still happy. We're going to remove the GP cone. We're going to place that into our disinfecting ring, and don't forget the GPs are usually not sterile in most cases because they just lie on them in a box, so they need to be placed into sodium hypochlorite. And then we're going to do our irrigation protocol, which is sodium hypochlorite activated, EDTA activated, sodium hypochlorite activated. And then, because it's quite wide, what I don't want to do is I don't want to push these paper points through this wide open apex, despite the fact that these paper cones, as I say, they're 50 and the apex is 50. So I'm going to measure a paper point and use that as a kind of a guide, so I know at which point where I need to be gripping the other ones at, because I don't want to push the paper cones into the measuring block because it's not sterile. And then I've got a more controlled way of making sure that I'm only drying the canal space rather than pushing it through. If you push a paper point through the apex and it touches the tissues, it'll just bleed, okay? So we're ready to set up for our obturation. I'm measuring the Bioceramic. I'm using one fill here to the correct, almost maybe 2 millimeters away from the working length. I'm going to pick up the GP cone. I am going to dip it in isopropyl alcohol to kind of get rid of the residue of the sodium hypochlorite, air dry it, crimp the tweezers to make sure that that's ready to go, and then I'm going to remove the residue from the ham file. And give it a bit of a blow off, and I'm going to place that to one side, and then we're all ready then just to pick things up and just do it in a wanna. And then I'm going to backfill the canal space with our Bioceramic. Directly injecting Bioceramic into the canal space should only be done with direct vision with a microscope. And then once the Bioceramic is being injected into the canal space, I like to maybe do the sort of close to the apical third, coronal and mid. And then I'm going to introduce a ham file to about, again, 2 millimeters away from the working length. And this introduces the Bioceramic into the canal space nicely. And then we're going to just very, very gently push the cone to length. Again, I'm just doing it very, very gently because I want the sealer to sort of flow around it. And then, another problem with a small access is cutting off the GP. Because I'm using the single cone technique, when I sometimes remove the excess in very, very small access cavities, sometimes the whole cone can be picked up by my heated plugger. So that's another kind of difficulty when we are thinking about a small access. And I notice here that when I look at the canal, I'm just about to condense it down. I think, well, maybe there's a little bit of space here. This canal's quite wide, and I think probably this will benefit from placing another cone in its adjacent to the massive apical cone. So I'm just going to get another GP cone. I'm going to disinfect it, and what I notice is here, as I push this kind of accessory cone to length, it actually goes quite far down. So I'm quite happy that I've placed this GP cone in place. And to be honest, I've backfilled this tooth completely, and I've probably filled it really, really nicely. But on occasion, I have done this, not placed an accessory cone, and there's been voids, and it's always very, very annoying. So, you know, doesn't cost much to put another GP cone in. We're going to, again, remove the excess. We want to make sure that we're not pushing out or pulling out the whole GP cones. And what's really, really important in these types of cases is that you're getting the GP below the CJ, because what you don't want to do is you don't want to leave GP in the coronal tooth tissue, because it can stain the tooth. And this patient's got some nice crowns and things. So you'll notice here that, you know, we've condensed it all down, we've given it a bit of a clean up, and it's all nicely finished. And in true I Love the Pulp style, you know, I had a whole video of me putting Vitribond in here and backfill it and things, and the video was corrupted, so we're going to have to leave it here at that point. But I do use Scotch Bonds. Scotch Bonds are really, really good bond. You don't have to etch and bond the tooth separately. And of course, we know with very, very, very small access cavities, trying to wash out etch can be really, really difficult. So overall, we look at the post-op radiograph, and, you know, I saw this and I was like, oh, looks fantastic. We've got a kind of nice little S shape. It's all to length. And, you know, I'm really, really, really happy with this result. So overall, if you haven't subscribed already, please hit that subscribe button. Again, if you want to support the channel further, join the membership program, and I will see you next week, next Friday, in the next video. Have a nice day. Bye-bye.